Now moving on to our scientific session, I would like to invite our chairperson, Professor Abdul Jabbar, who is a founding member of Pakistan Endocrine Society and a past president of Pakistan Endocrine Society. Sir, kindly join us on the stage. Our second chairperson, I would like to invite Professor Emerita Tasneem Ehsan. I don't think her name needs any introduction. She's a founding member of the PES, and she is a professor of endocrinology at OMI Medical Institute of Karachi. Thank you. So moving on to our first talk, which is on the improved fertility of women with obesity through healthy lifestyle. I would like to invite Professor Jean Patrice Jean, who is a professor of medicine at University of Sherbrooke, Canada. He's a past president, Canadian Society of Endocrinology, and board member of International Society of Endocrinology. Welcome, sir.
Thank you, Dr. Hafiz, for this very nice introduction. I feel very much honored to be the first one to give a talk in this conference. I believe this is really a great conference. I've seen the agenda, and the agenda is very interesting. I look forward for the next presentation and the discussions. So I'm very privileged, I think, to be invited here and in Pakistan. In fact, it's my first visit in Pakistan. I visited yesterday, and the city of Islamabad is very beautiful. The food is amazing, and I've met very nice people. So I'm very glad to be here, and I thank the organizing committee for the invitation to come here and give a talk on one of my favorite subjects, in fact. So the how to improve fertility of women with obesity through healthy lifestyle. So, hopefully that works. My disclosure, I received an unrestricted grant from Ferring, Canada for a investigator-initiated study. In fact, I will discuss this study today, the Fit for Fertility trial. But this trial is mainly funded by public grants, so this is a minor contribution, and I have no other conflict of interest. So during this presentation, we'll discuss obesity and women's health, also the role of lifestyle intervention, and finally, we'll discuss the preconception lifestyle intervention Fit for Fertility that we have conducted in Canada in my university in Sherbrooke. So first things, it's important to consider. I think many of you know that, but it's not something that the population is very well aware. Obesity is bad for your fertility. It's true for men and women, but we have more evidence in women, so the discussion will be mostly regarding women's fertility. So you know that the definition of infertility is a failure to achieve a clinical pregnancy after 12 months of or more of regular unprotected sexual intercourse, and infertility is quite common. It's common in North America. It's 10 to 15% of couples that are affected by infertility. So that's a significant problem. And infertility has many causes, as you know. For example, sexually transmitted infections, smoking, stress, endometriosis, advanced age, damage or blocked tubes, premature menopause, but it also probably in North America, in fact, the main cause of infertility is an endocrine disorder that you know very well, polycystic ovary syndrome. There is also other ovulatory disorders and other hormonal disorders. But obesity is also associated with infertility. It can cause infertility by causing or increasing the manifestation of polycystic ovary syndrome, but also directly, probably, and we'll discuss that. So obesity is also a very important problem. As you know, it's very prevalent everywhere in the world. It's a global pandemic, and Pakistan is also affected. So there is this demographic and health survey that has been conducted in a representative population in South Asia countries, Nepal, Bangladesh, Maldives, and Pakistan. And in fact, in Pakistan, more than 5,000 women were surveyed, so between 15 and 49 years old, and that was between 2017 and 2018. And if we use the cutoff of overweight and obesity from WHO, the cutoff of BMI of 25 or more kilogram per meter square, the prevalence in that survey in Pakistan of overweight and obesity was 52%, which is very important. I don't have the number specific for obesity, but usually it's almost half of that number. And in fact, Pakistan has the highest prevalence of overweight and obesity among those 4 countries of South Asia. So it's prevalent, it's important, and it has impact on couples' fertility. So this is a very large study, the Danish National Birth Cohort, and I think this is one of the best evidence that we have on the impact of obesity on fertility. And this cohort included almost 48,000 pregnant couples, and they look at the adjusted odds ratio for a time to pregnancy of 12 months or more, which is the definition of infertility. And in that study, if the woman was obese, and if you look the last line, a BMI of 30 or more, then her odds of infertility was increased by 78%. So it was significant. It was also true for men. So the likelihood of infertility was 49% increase in men with obesity, a BMI of 30 or more. And if both members of the couples, men and women, were both obese, then it was even more. It was almost tripled the risk, the likelihood of infertility, which is even more than the risk, the combined risk of men and women together. So it's more than additive. So really, obesity impacts couples' fertility. But also, if we look at women with normal ovulatory cycles, their fertility is also reduced if they have obesity. So it's not only through anovulation or polycystic ovary syndrome, but it looks like obesity can have a direct impact. So this is an example, a cohort of more than 3,000 subfertile couples in which the woman was ovulatory and with at least one patent tube. So looking at the more direct impact of obesity on fertility. And in fact, in that study, they found that the conception rate decreased steadily after a BMI of 23 was the reference here. So you see that with a BMI of 35, the conception rate was reduced by 26%. And at a BMI of 40, it was reduced by more than 40%, almost half the fertility of a healthy weight person, woman. And they calculated that for every additional BMI between 30 and 35, the conception rate decreased by 4%. So this is important. Even in ovulatory women, it seems that obesity has a direct impact on fertility. And when these women get pregnant, obesity has also an impact on their pregnancy, the outcomes of their pregnancy. So this is a large meta-analysis, I think one of the best evidence regarding pregnancy outcomes in women with preconception obesity. They look at individual data from European, North American, and Australian cohorts, more than 250,000 women. And they found that preconception obesity increased by 2-fold the risk of any pregnancy complications. And for example, for gestational diabetes, in fact, it was increased by 4.6-folds. So this is important. And in fact, the risk was even higher if the woman had an excessive gestational weight gain. So the risks are additive or are even more increased. So if the woman had a preconception obesity with a gestational weight gain of 1 standard deviation or more, her risk of complication was 2.5-fold and more than 2-folds for any pregnancy complication. And so this is really an important complication in women with preconception obesity. You know that they have increased infertility, they have increased risk of pregnancy complication, but also their child has an increased risk of childhood obesity later on, of early diabetes development, as well as cardiovascular disease. So there is also an impact on the next generation, on the kids. And in fact, a baby girl born from a mother with obesity is more likely to develop obesity and would have been at higher risk to be obese herself for her next pregnancy. So this perpetuates a vicious circle of obesity through fetal programming. And it might be, I think, very important to try to block this vicious circle by improving preconception and pregnancy obesity. So it has a lot of implication, but what can we do about it? So I will show you some results. Most of the study looking at management of obesity through lifestyle, so that's we will not discuss medication tonight, but most of those studies have been done in women with polycystic ovary syndrome. It's a very prevalent and common disorder. And in PCOS women, weight loss with or without exercise is effective to improve ovulation, fertility, as well as live birth rates. In fact, if it's introduced before fertility treatment, and that has been shown by a study from Dr. Legros in the United States. It seems that a weight loss of only 5 to 10% is usually enough to improve fertility. So it is recommended as the first-line intervention in women with PCOS in order to improve their fertility, but also their general health, even if they don't want to get pregnant. Regarding women in general, not necessarily those who have PCOS, so with or without PCOS, I think one of the best evidence comes from this study, the Netherlands Lifestyle Program Randomized Controlled Trial, published in the New England Journal of Medicine in 2016. And in that multi-center trial, they included 564 women with infertility and a BMI of 29 or more. And these women were randomized to either a 6-month lifestyle intervention prior to fertility treatments. So women had to postpone their fertility treatments for 6 months. They do the lifestyle intervention, and then they go on fertility alone without the lifestyle intervention. Or the control group start their fertility treatment right away without waiting 6 months. In that study, the lifestyle intervention was monthly visits with coaches plus 4 phone calls. They had nutritional and exercise advice by those coaches. And the intervention was based on motivational counseling with individualized goals, as we should do in the management of obesity. At the end of the follow-up, it was I think the follow-up was for 2 years. The outcomes was 2 years, but the intervention was for 6 months. So at the end of the 6 months, 22% of the participants had discontinued the lifestyle intervention, which it's high, but it's expected in that kind of lifestyle intervention program. It's not rare, that's the number we see usually. And in those who completed the program, 43% in the intervention group lost at least 5% of their weight, as compared to none, in fact, in the control group. And what were the results? So after 24 months of follow-up, they showed that women with in the intervention group, in fact, had 26% of natural conception, natural pregnancies without fertility treatments, as compared to 16% in the control group. So they improve their probability, their chance of getting a natural pregnancy, then that was significant. The intervention group used significantly less fertility treatments as expected. But in that study, the primary outcome was not reached. And for example, the live birth rate here was 44% in the intervention group as compared to 54% in the control groups. So there were less live births at the end of the follow-up. And if we look at, so that's preconception, fertility. We know that it can improve natural fertility and live birth in PCOS women. It's not clear in the general population, but these women get pregnant. And when they get pregnant, what is the likelihood of lifestyle intervention during pregnancy to improve the complication that I've mentioned? So this is a very large meta-analysis of studies on behavioral intervention, lifestyle intervention, to promote a healthy weight gain, so to prevent excessive weight gain during pregnancy. Included 68 studies, more than 25,000 women, and they find that interventions was associated with reduction in the risk of gestational diabetes. The absolute difference in risk was 1.6%. Seems small, but it's the number needed to treat of about 62, which is not bad. It reduced also emergency C-section, macrosomia, large for gestational age, and it also reduced in the meta-analysis the postpartum weight retention at 12 months, so after 1 year. The difference is not very big, but it seems to prevent that problem of postpartum weight retention. So lifestyle intervention seems to be beneficial during pregnancy. So that's something, lifestyle intervention, that seems to be interesting for fertility during pregnancy. So that's something we can do, but what do we do? So in Sherbrooke, we decided to do something. We put together, we implemented the Fit for Fertility lifestyle intervention. This intervention aims to implement progressive and sustainable lifestyle changes in the women with infertility. It's a low-intensity intervention. You'll see the description. And it starts preconception, and it continues during fertility treatments, and it continues during pregnancy, which is unique. There's no other studies described that have been published in the world with that kind of design. It includes individual meetings with a dietitian and kinesiologist. Again, it's quite unique to have professionals. It's not only coach, a nurse, or a different kind of professional. It's a professional in diet and a professional in physical activity who met the participant at 0, 3, 6 weeks, and then every 6 weeks. And again, like the study published in New England Journal of Medicine, our intervention was based on motivational interviewing, and the women were supported to set SMART objectives. This was combined with group sessions. We developed 12 different weekly group session, and they were provided weekly. The first part was 45 minutes of workshop on nutrition or psychological support, surgical principles, motivation, etc. And the following 45 minutes was a demonstration of 12 different types of physical activity that the woman can practice at home after that, if they like the different activity that has been proposed. And we try to involve the spouse as much as possible. And again, such as the study published in the New England, there was no fertility treatments during the first 6 months of participation. So that's a principle, the intervention alone for the first 6 months. So we decided to pilot test this, the effect of this intervention using a randomized controlled trial in our clinic in Sherbrooke. So we recruited women with obesity, BMI of 30 or more, or overweight, a BMI of 27 or more if they had polycystic ovary syndrome, because we know that these women might benefit more, who consulted at the fertility clinic in Sherbrooke. They were randomized to the control group, who can start fertility treatments right away, or to the intervention, so the Fit for Fertility program, for 6 months alone. So the woman had to postpone the fertility treatments, and then in combination, and the follow-up, maximal follow-up was 18 months or end of pregnancy. So this is the flow chart of the recruitment. In that study, we recruited 130 women, were randomized to the intervention or the control group. We had 3 breach of selection, so the intent to treat analysis is on 127 women. And then we look at women who persisted at least 6 months. So we have 108 women, so it's a loss of only 15% compared to the New England Journal paper who had 22%. It's even better. And this is the results I will show you the results on that population who persisted at least 6 months, so our modified per protocol analysis. And we followed these women up to 18 months or end of pregnancy. So if we look at those women who persevered or persisted at least 6 months, our modified per protocol analysis, this is the baseline characteristics. So these women were aged 30 years old. Their BMI was quite high, around 40 kilogram per meter square. And the group were comparable for BMI, age, waist circumference, fat mass, PCOS proportions, about 63% in total. And they were similar on their baseline diet and physical activity, and that was assessed by a questionnaire. So, but did the intervention made any change regarding anthropometry? So yes, in fact, our women in the intervention group lost 3% of their initial weight as compared to 0.4 in the control group. So that was significant between the two groups. The difference doesn't seem very big, but it's probably metabolically impactful. They also lost significantly more waist circumference. And this is in the women who persisted at 6 months, and we have data at 6 months. So the number is a little bit lower, 43 and 42. Did they change their lifestyle? Yes, they did. They increased significantly their consumption of fruits, of whole grain products, milk, and they increased the number of breakfasts per week, which is probably an important aspect of a good, healthy diet. Did they improve their physical activity? Yes, based on the questionnaire, they increased their exercise-related energy expenditure significantly. They also reduced their sedentary time, and we did a functional test, the 6-minute walk test, and they increased by 18 meters in average their 6-minute walk test, which is quite clinically significant, but was not statistically significant in our study. So that's the results regarding anthropometry, lifestyle. So it was good, but what you want to know, did it improve fertility or pregnancy rates? So in the control group in our study, the pregnancy rate was at 18 months or was 38%, and it increased to 61% in the intervention group. So don't forget, they don't have fertility treatment for the first 6 months. It's only lifestyle, and then they go on to fertility treatments. But still, in our hands, in this study, they significantly improved their pregnancy rate. And if you look at spontaneous natural pregnancy without fertility treatments, it went up from 12% to 33%. So it almost tripled, and this was highly significant. And this might have consequences to reduce the need for expensive treatment, fertility treatments. Most importantly, live birth rates, it was 37% in the control group and increased to 51% in the intervention group. So this is a good difference, 14% in absolute. A number needed to treat, which is 7, would be very clinically significant if it was statistically significant. So we don't know if the difference is true because we were not able to reach statistical significance. So that's why we are running now a multi-center randomized control trial to have enough power. So these results are very interesting, seems really to have an impact on fertility, even if they don't start the fertility treatments right away. But what happened during pregnancy, I think that's important. We look at those numbers. Numbers are getting smaller, only 20 controls, 26 intervention, because they have to get pregnant and we have to have data on them. They have to have a early pregnancy visit and follow up during pregnancy. We didn't see difference in gestational diabetes, but if we look at gestational diabetes requiring insulin, in the control group it was high, 42%. But in the intervention group, it was only 12%. So it seems that we were able to reduce that outcome, which is very pertinent. And looking at emergency C-section during delivery, it was high in the control group, 20%, but we had none in the intervention group. So it seems that our intervention was able to reduce that outcome. So in conclusion, my key messages is that in women with infertility and obesity, an interdisciplinary intervention supporting the adoption of healthy lifestyle, it is feasible and it is effective to reduce anthropometric and lifestyle parameters, and it also improves fertility, mainly the occurrence of a spontaneous pregnancy. This has the potential to reduce the cost of fertility treatments. And when it's maintained during pregnancy, this program seems also to reduce clinically relevant complications during pregnancy. So in conclusion, we believe that the Fit for Fertility program, or such lifestyle program targeting women with infertility and obesity, appears to be an efficient approach to improve fertility, but also the health of pregnancy, the newborn, and probably the future family. And it's really an ideal period before pregnancy, during the preconception. It's probably the best time to intervene and to improve couples' fertility and their child's health, showing here a picture of one of the couples who participated in the study. So the boy is born during the intervention, and the other baby is born after the study without any fertility treatments, just naturally. So thank you very much for listening, and I don't know if you have time for questions.
I think we have got a question here.
Hi, I'm Dr. Abbas. Excellent presentation, Jean Patrice, as usual. Quick question. You mentioned in your study that the type that's lean polycystic women, women with a lesser BMI, were excluded from the study that you meant, if I read the slides well. Do you think that intervention, in your personal experience, does that also help a lean polycystic female as well, or is it not only limited to someone who's obese?
So we limited, so you're right, it's 27, less than 27 were excluded, women with PCOS and less than 27 of BMI. We know that, you're right, it's probably beneficial for some women with PCOS below 27. Probably obesity is 25 in women with PCOS, and probably overweight is 23 of BMI because of their risk. So it's, in my practice, I advise to lose some weight if they are above 25 and even above 23. But we know that lean women with a BMI close to 23 probably doesn't benefit from losing weight, because they are close to, you don't want to be too lean in order to have a hypothalamic amenorrhea and impairs fertility. So the treatment window is small if they are below 25 probably, or close to 23. So to be safe, we use 27 as a cutoff in that study. So we know that they will benefit more than the regular population.
Thank you. And I think that also addresses the point that probably if you, the weight loss might not be helpful, but I think lifestyle changes could be beneficial, but we don't have enough data on that.
Yeah, that's perfectly right. In fact, I'm talking about weight, but we believe that lifestyle is even more important than weight. And during our intervention, we tend not to be weight focused. And we really think that lifestyle is probably more important, in fact, than weight loss.
Thank you.
Hi, Doc. Zakir Alvi from Karachi. Excellent presentation. I enjoyed every bit of it. A question. So it was very nice when you explained how obese mothers perpetuate and give you more obese mothers in the next generation. I just wonder how much of that is genetics and how much of that is in utero environment of the baby. Now, is there any study in the past which has shown that improving a mother's weight during pregnancy or just before pregnancy helps reduce the obesity in the child or the mother?
Yeah, that's a very good question. So there is evidence in animal models that it's really obesity during pregnancy or preconception. You can have all the controls you want in animals, and that there is really fetal programming that can be an hypothesis for that. But in humans, intervention study have not been done really. So we are doing actually the follow-up of our kids. They are 6 to 10 years old now, and we want to answer that question in our kids. The number is small, so other studies need to be done, but they are not. There are other studies, but they are not published. So,
Expectations.
because of small sample size, I think we would have difficulty to have significant results, but we hope for a trend. We are doing DEXA scan, so we don't expect that the weight will be different, but fat distribution might be different, and also metabolism so might be also affected. So we are looking at more sensitive data in those kids.
Thank you. My name is Dr. Zaman Shir. Thank you very much for your elegant talk. My comment and question is 22% participants, they discontinued after 6 months after intensive lifestyle intervention. This is shown in Netherlands lifestyle program. Only 6 months study and 22% discontinuation in spite of so much intervention, regular classes, teaching, education. So it is easy to say, difficult to do. And we are so busy in doing so much exercise or doing so much diet. And while is any study done after pharmacological therapy, weight loss, and effect on infertility, because it is comparatively easy, just put injection, and
Yes.
do nothing.
Yeah,
so
I understand.
What's your opinion?
Yeah, I mean, our intent to treat analysis, if we include everyone, even those who drop out, we see that there is a almost 10% difference between the groups. So even because of all those problems of compliance, we still have an improvement. So I think it's still important overall. But you're right, medication might be easier. The problem is that women cannot be pregnant under medication. They have to take contraception. So that's a barrier. And then they have to stop the medication in order to become pregnant. If you look at the GLP-1 agonist, the long-acting, they have to wait 2 to 3 months. The short-acting, they have to wait probably 1 month before they can get pregnant. And there's a risk of rebound during that 1 month or those 3 months of the weight. And there is a risk of rebound during pregnancy. And there is a risk of excessive gestational weight gain, to my perspectives. So I think lifestyle is really important to reduce the risk of, so we don't have those rebounds if you maintain the lifestyle and you're successful. So that's the problem with the drugs. But studies have not been done, so we have to really to look at the potential. But if you lose weight with the drugs, you will improve your fertility the same way, for sure. But there's there's more study to do.
Thank you so much. Thank you so much, Professor. I will request Professor Abdul Jabbar to give a